Namaste and good afternoon. Hope you've all been well and safe. This is Dr. Srinidhi Chidambaram, and I'm very happy to see you all again. We at Apollo Hospitals have always been at the forefront in creating channels of knowledge so that you not only prevent diseases and always live a life of good health, but also have authentic information on hand when you or your loved ones develop health issues. In the category of non-communicable diseases, a word that conjures up deep concern and worry in most of us is cancer. But the more we talk about cancer, understand what causes it, how you detect it early, how to access the latest methods of diagnosis and treatment, and above all, how to live a life of positivity and quality, the more easy it would be to conquer and survive cancer. So here we are presenting the Cancer is Conquerable series, where we tell you in a series of sessions what to expect whether you or someone you love has cancer. We will discuss some important organ-specific cancers in the forthcoming sessions, but also on important aspects of screening, prevention, and survivorship. You know very well that cancer is not one disease, but it is one of a large number of diseases characterized by the development of abnormal cells that divide uncontrollably and have the ability to infiltrate and destroy normal tissue. It is an important cause of death and disability in the world, but you must understand that survival rates are improving for many types of cancer thanks to improvements in cancer screening, treatment, and prevention. Today, we're going to talk about screening and early detection. So screening is nothing but certain tests that are done for specific types of cancer before the signs and symptoms appear. And that's important to know because the earlier you detect cancer, the easier it is to treat and cure. Another aspect is risk, and there are certain modifiable and non-modifiable risk factors for cancer that we must be aware of. And we must also know the link between risk and screening, because sometimes if you know your risk, you may need to have earlier or more extensive screening or even some interventions. So to illuminate and give us an overview of all this and to explain to us what is the importance of early detection and how to detect, what are the screening mechanisms for cancer, I'm privileged, delighted, and very honored to welcome Dr. Rakesh Jalali, Medical Director and Lead Neuro-Oncology of the Apollo Proton Cancer Center and Oncology Vertical of the Apollo Hospitals. Dr. Rakesh Jalali is an internationally renowned key opinion leader in oncology, particularly known for high-precision radiotherapy techniques. And over the years, he has done path-breaking research in the field of cancer treatment, enhancing the quality of life for innumerable cancer patients and developing appropriate research models. He completed his MBBS from the Government Medical College, Jammu, and his MD in Radiotherapy and Oncology from the PGI Chandigarh, where he passed out with the distinction awarded the Merit of First Order. He was a senior researcher at the academic unit of the Royal Marsden NHS Trust, London, where he particularly researched the stereotactic radiotherapy program. He has been instrumental in establishing neuro-oncology units in several key hospitals, instrumental in establishing the Indian Society of Neuro-Oncology, and a much sought after speaker, researcher, and teacher, and also famed for his commitment to charity and promoting equitable cancer care for patient populations in the developing world, founded the Brain Tumor Foundation of India, which is an internationally recognized charity organization dedicated to the welfare of patients with brain tumors and their families. Hello, Dr. Jalali, and welcome to this discussion. I'm so happy that you've made the time to join us, and we look forward to hearing from you about early detection, and its importance in cancer.
Thank you so much, Dr. Srinidhi Chidambaram. It's a great honor and pleasure to be part of this wonderful series. And very many thanks for the kind introduction as well. So I've been in oncology now, almost 30 years, initially as a student and in Tata Memorial for almost 18 years, and now associated for several years with the Apollo group, in particular this Apollo Proton Cancer Center, which is again a very unique cancer facility. Now, as you absolutely rightly pointed out, the non-communicable diseases are in particular rise, especially in the lower middle income countries or in the developing countries. It was always believed that the cardiac disease, diabetes, hypertension, and cancer are primarily a disease of the West, but now we know that maybe because of the population, because of the lifestyle, because of other factors, it has been estimated that about 2/3 to about 70% of all the cancer patients would actually reside in these countries. There was a fascinating study done several years ago, which was published in a very major international journal, Lancet, 2 years ago, where they mapped out several countries and several continents throughout the world, and in particular looked at the urban-rural divide of the cause of death. And there is a significant transition, demographic change, which has happened throughout the world. In primarily, basically, cardiac disease used to be always number one from the non-communicable disease, but in the next decades, unfortunately, cancer is likely to dominate the number one cause of death in the developed world at the moment. But unfortunately, because of rapid urbanization, because of several other lifestyle, environmental factors, which are mainly happening in the lower income countries like India and other developing world, the same demographic transition is unfortunately going to happen in our countries as well. To give you specific information, at the moment in India, for example, we detect anywhere between 14-15 lakh cancer cases every year. If you take a population of 100,000 or 1 lakh in any part of the country, every year we detect about 100 to 110 or 105 new cancer cases, not the previous cancer cases. If you combine the previous cancer cases prevalence and the new, and then that will be quite a significant, that is about 25 to 30 lakh cancer cases that we have in our country. So every year per 100,000 population, we detect roughly about 100 people every year with new cancer. Now, what is very interesting and sobering thought is, if you go to rural populations, and there are several studies done, in fact, in TMH, in Tata, we had adopted some districts in Maharashtra, Barshi, many years ago by the Indian Cancer Society in 70s, and prospectively looking at their lifespan. In fact, our chairman, Dr. Pratap Reddy, also did a similar exercise in his native village. And we have the same kind of a data emerging that there the incidence of cancer was about 30-35 per 100,000, say 20 years ago, and now it is about 40-45. But in urban cities like Chennai, Bangalore, Delhi, Mumbai, Hyderabad, the incidence of cancer is as high as 150 to 160 to 170 per 100,000. So that is a very interesting transition. Now the question is why there is such a significant and very obvious and very dramatic urban versus rural divide in the detection of cancer. And one of the reasons is, obviously, some people may say it is because we don't detect the cancer so much in rural because of the access is not there. But two districts I mentioned to you, one is the Chittoor district where our chairman, and also the TMH study which goes for the last 40-50 years. There has been a very good kind of an environment where we are tracking the people. So it is not a lack of access, but clearly there is a difference between the two. And it could be either because of the environmental factors, it could be the lifestyle, can be obesity. We will discuss as we move along what are the potential risk factors for cancer. And therefore, there is a difference. Even in the PURE study, which I mentioned 2 years ago in the Lancet, was called PURE study. It's called Prospective Urban Rural Epidemiological Study. That's what it's called, PURE. In that study also, apart from aging is a risk factor. As you grow older, as the country grows older, the incidence of cancer increases. And that could be a factor also because you expect urban slightly better in that sense as compared to rural. But it is also the lifestyle and environment. We don't think too much about environment, and they label environment also as a factor in these. So these are very interesting emerging demographics which will shape up the healthcare policy, particularly the NCD and cancer, as we move along in the next 20 years or so. And also, it is absolutely critical for us to sensitize our fellow colleagues and fellow citizens about the enormity of the problem, and also how to, whatever we can, to some extent, mitigate it with the right awareness, right platforms, right and smart and careful lifestyle changes, and also the early detection and screening methods as we discussed. So this is kind of a background about the issues that we face at the moment as far as cancer is concerned.
So most people are now aware that there are some screening tests for cancer, and people now, of course, with the concept again pioneered by our chairman, this whole health checks and packaged programs where they get screened is there. But still, people are not fully aware on what to do this, because now there is such a plethora of tests and labs and investigations. So, what are the screening tests for cancer, and what is ideal? Which is, of course, I'm sure age appropriate, but how does that work?
So it's a very interesting and very difficult question actually also, because many people ask us in the clinic also, is there a blood test? You just do a blood test and then detect whether the cancer is there or not. And can it be 100% proof? So unfortunately, it's just not the case. One of the reasons is cancer is not just one disease as such. Cancer is quite varied, it's quite diverse, it's quite heterogeneous, especially from the organ that it starts with. So each organ of the body can be affected. There are like hundreds and even 1,000 types of cancers. It also depends on the stage. Each cancer in a particular, each individual can also have a variation as it would progress over a period of time. So therefore lies the enormity of the challenge in identifying the appropriate screening test methodologies also. And you are right that therefore, in spite of so much progress in the last 20, 30 years throughout the world, we still do not have kind of a very standard definition and standard screening packages and standard tests which every single person has to do throughout the world. Nevertheless, there has been tremendous amount of progress, especially in the last 5, 10, 15 years, and I'll just elucidate briefly which are the tests to be done and why they are done and what are the pros and cons of those. Number one, cancer in women, I will start with, is breast cancer throughout the world. And the second commonest is cancer of the cervix. Cervix is from the womb, not from the body uterus as such, from the opening of the uterus, and that is called a cervical cancer or a cancer of the cervix. And then, of course, you have cancer, other cancers of the head and neck, esophagus, body uterus itself, liver, head and brain, lung, and so on and so forth, and prostate in men. As far as the breast cancer is concerned, why I chose breast is because of 2, 3 reasons. Number one, it's an extremely important cancer. Previously in India, cervical cancer used to be the number one cancers for all these years, even when I was studying and I was working in the initial part of my career, except major metropolitan cities like Mumbai. Bombay was always having breast cancer right from 70s and 80s as compared to the rest of the country. But now, unfortunately, all metropolitan cities like Chennai, Delhi, Hyderabad, Bangalore, all these cities, and also tier 2 cities, also now breast cancer is number one cancer. So there has been a transition of that. And it's also because cervical cancer has come down, which I'll talk to you in a subsequent interaction. So the reasons for increase of the breast cancers are, number one, breast cancer risk factors include First of all, age. As you age, so the overall age population is increasing. At the moment, the average life expectancy in India is about 65, 67 years in men, and women always do better than men in all aspects of life, including life expectancy. That is about 68 to 69 years. So that is the median life expectancy. But in an urban population, it can be 75 to 80 to 85 years. So that is one risk factor. Second is obesity. Obesity is an extremely important risk factor and is related to the hormones of estrogen, which are accumulated in an obese person, an obese woman, and she has at a higher risk of developing breast cancer. Number three is nulliparity, which means no children, or late age at marriage, or late age where you have the first child. Fourth reason is if you have not breastfed your child. So that increases the risk of, because when you do the breastfeeding, why pregnancy decreases the risk of breast cancer is because it is dependent on the hormones, estrogen and progesterone, which are on the monthly menstrual cycles. But during pregnancy, you have about 9 months where there is no menstrual cycle. And that is a protective mechanism which a mother gives for herself to reduce the risk of breast cancer. And therefore, if you breastfeed a child, your actually menstruation will be further delayed by 6 months to 9 months. That gives an additional benefit. But if you do not breastfeed, then the menstruation can come earlier, and therefore breastfeeding is also correlated with the reduction of the breast cancer. Fourth reason is if you have any family history. If some woman does have breast cancer, the mother and the sisters and the children are at a slightly higher risk of developing breast cancer. So the screening methodologies become even more important. Lack of exercise, highly saturated food habits, environment to some extent, smoking and alcohol, and the use of estrogen-related contraception and hormone replacement therapy sometimes in a postmenopausal women. These are the 10, 12 risk factors of breast cancer. And because of the urbanization, because our girls are now, finding independence, economic, which is fantastic, which has to be done, no doubt about it. But unfortunately, because of the urbanization, they marry late, or they don't have children, or sometimes they don't breastfeed the children, or they have only one child. Sometimes, 2, 3 children are optimal because you get 2, 3 pregnancies and you give 2, 3 protective mechanisms. And therefore, in the Western population, in Europe and West and America, where it is much more pronounced, all these risk factors, and including obesity and environmental factors. So therefore, in US, for example, the average of, I told you, India is about 100 per 100,000 population. In the US, it is about 300 per 100,000 population. Much more risk of developing cancer in the Western population. It's also partly because their average life expectancy is higher. And about 1/4 to 1/3 are primarily breast cancer. So in an urban population like Chennai, Mumbai, Delhi, Hyderabad, the risk of breast cancer is about 25 to 30 per 100,000 population. About 1/3 primarily belong to the breast cancer, very high risk. Therefore, screening methodology, awareness, all these factors are extremely important. So therefore, breast is number one. Also, second equally important part is, which I firmly believe, is that a woman, especially in our countries, is such a fundamental core of the entire family. So your mother, wife, sister, daughter they have to look after their breast. They have to look after their health, because if the woman is not healthy, the whole family, the entire society, entire nation, it has a societal ramifications. And the third aspect, of course, to still to some extent, unfortunately, in our country, women are not always given the number one priority. They themselves are shy and are not very forthcoming. Even if they have the lump, that sometimes, unfortunately, the husband or the mother-in-law will say, oh, there's nothing there. Maybe she doesn't want to work. So whether we like it or not, they are very much prevalent in our society. So ultimately, it is the woman and even the men, overall health of the family and the society. We have to make sure that they look after themselves. They are not shy. In that sense, if the screening methodology is adopted with some mandatory health checkup, that gives the confidence and it motivates the family, including the man, the husband, or the father, or whosoever, or the son, to take that lady to the health checkup to get herself checked such that she gets educational. It's an educational exercise also, and it also helps in the screening. So I'll just finish with breast. I think
So with
I
breast,
told you about the risk factor. Sorry, go ahead.
no, I was just going to ask you. So for the breast cancer early detection, what kind of
The factors. Yes,
tests?
absolutely. That's a relevant question. So there are 3, 4 things we have to do. Number one is you must do a breast self-exam every month. Whichever lady, particularly after the age of 30, you must know your breast. Each breast is different. Always there are manuals. Apollo also has several manuals, both visual platforms also these days. So the YouTube, it's very easily available, but there's also written information in most of our hospitals whenever they visit, including other hospitals also. It's not only Apollo, it's the whole nation kind of thing, global thing. So always the left breast has to be done with the right, and the left with the right. And also you look at the armpit, because the first station when the cancer goes is towards the lymph nodes in the armpit and also into the lower part of the neck. And there are methodologies to do it. In a young woman, the breast is relatively dense, so sometimes may be hard to detect, or you may find imaginary lumps also, particularly in the time of menstruation. So it takes a little time for you to understand. But typically, a woman should always do a breast self-examination. That is number one, just to be familiar. Number two is, I would actually say, low threshold. The moment, even if it is nothing, you feel something abnormal in the texture, if you feel a lump, there is any bleeding coming from the nipple, there is some ulceration around the nipple areola complex, there are some lumps around the lymph nodes in the armpit, or you are feeling unwell anyway, there is loss of appetite, significant loss of weight, some bone aches, some intractable cough for a long period of time. These are all the signs that there is something not good, correct. Visit your family physician or go to the nearest major hospital. It may not be even a cancer center. It can be any other hospital which has a preventive health checkup. And most of the hospitals, including all Apollo hospitals, have that thing either digitally or in a physical manner, and they will get themselves checked. So one is the breast self-examination. Second is the low health. After the age of 40, it has been recommended that you should get a mammogram done. Mammography is a type of method of X-rays where a very, very early breast cancer, when it is in the pre-invasive stage, you can detect some abnormality. We may or may not do anything about it, but the radiologist and the doctor will look at it. There are methodologies, there are criteria as to which are suspicious lesions where we can do a directed biopsy, or which are safe and benign, which you don't have to worry about, but it sensitizes the woman about the importance of the health checkup. So 40 to 45, typically we say every 2 years. Beyond 45, every year, once a year, you must do a mammogram. If by chance mammography is difficult, sometimes it is a very dense breast, we also combine with an ultrasound, what is called sonomammogram. You do a sonography and you do a mammography. The yield is very, very high in an experienced person, 90-95%. These days, we do it on a digital platform also. You don't need a film. And in a very young woman, maybe in late 20s or 30s, particularly with family history or something, sometimes we also do MRI examination, because that will detect the breast lump, or if it is suspicious of a breast cancer, very, very nicely. And then again, what we have seen sometimes is either by the lack of education of the woman or the family, but also sometimes to the doctors. We need to educate our general practitioners, all the doctors should know how to send the person in an appropriate person. I'm not using the word patient because they may not have cancer. So they're just a normal person at the society. But that revolution, that insight, that motivation, it has to be part of, like we pay electricity bill. Similarly, did we do our annual mammogram? It should be as routine and mundane as it sounds. And then it will really, and there is tons of data out there in the West, including in India, that if you adopt these methodologies, your early detection will become better. As everyone knows, the earlier you detect cancer, the cure rate becomes very high. In a pre-invasive cancer or even in stage 1 cancer, when the cancer is localized less than 3 centimeter or 2 centimeter lump, you can cure the woman, not for 2, 3, or 5 or 10 years, for the rest of her life in more than 90% of the cases. And if it is stage 2, now it is 70 to 80%. There is tremendous advance in cancer treatment, also, by the way, in parallel. But at any point of time, every oncologist, every doctor, every healthcare professional, including yourself, Dr. Sridhi, would love our cancer patients to come very early, such that, and we have to accept it. We have to accept that cancer is out there because of the numbers I told you. So the earlier we deal with it, the better it will be. So in general, these are the tests I just summarize again. Mammogram after the age of 40 years, every 2 years, after 45, every year. You may have to combine with sonography sometimes, but sometimes with MRI, that the doctor will tell you. If you still, because what is called interval cancer, by the time 1 or 2 years is there, you still have a slight chance. So you still must inculcate the culture of breast health examination yourself, or what is called clinical breast examination. Sometimes in rural places, or because of cultural taboos or the education levels, the woman may not do self-examination herself. But when she goes to an Anganwadi worker or a nurse or a doctor, there are methods where the clinical breast examination can be done in a healthcare worker in a mass screening methodology throughout the country, and they will tell us what is to be done. And then you do a biopsy, you detect, maybe it is no cancer, but at least you are free then, you don't have that issue. And if by chance, God forbid, you do detect a cancer, immediately access the treatment, and the cure rates are extremely high. Finally, two more things. If somebody has a family history, then this 40-45 years does not apply. As soon as even 25 to 30 years, the doctor will tell you whether to do a sonography. At least don't expose them to mammogram, because that has x-rays also in a young person. So then the threshold becomes lesser. And finally, is that whatever you may do the screening, there is also the counter argument that screening, some people then just forget it. They will not bother about their exercise, about their obesity, about their lifestyle. They no, I'm doing an annual mammogram. Mammogram or a screening test or a health checkup will not obviate or replace the need of a very disciplined, healthy lifestyle, particularly if you have one of those risk factors which I mentioned in the beginning, or you have a family history. That kind of completes the breast cancer part of the screening methodology.
I have one question here, Doctor, about we have been also, people ask about the genetic testing and so on for breast cancer. Is that part of the regular screening, or who needs to do that?
We do not do, there is no evidence based on large amount of clinical research and data that a routine testing is done for genetic testing. There are two particular genes which are implicated in breast cancer. They are called BRCA1 and BRCA2. And it is a slightly difficult test to do, but we do it routinely these days throughout the country. It takes few weeks for the report to also come. It is indicated only in 2 or 3 scenarios. Number one, if you have a family history. If you have a strong family history, a woman has detected a breast cancer, but then the risk towards the sibling or to the mother or to the daughter, even cousins sometimes from the maternal side particularly, and particularly if there are 2-3 families, then there's a genetic counselor, and then we advise to do BRCA1, BRCA2 testing. Second scenario is, unfortunately, sometimes the woman can have 2 cancers at the same time on the right and left. That also has a predisposition of a BRCA1, BRCA2. And thirdly, if there is an anxious family that we also encounter, and they don't want to release any charge, the memo is clear, there is no lump, but still they would like to do. So on a case-to-case basis, not in every case, we do the BRCA1, BRCA2 genetic testing for breast cancer. There are other genetic testing also to be done. For example, in colorectal cancers, the cancer of the intestines, of the colon and the rectum, which also both in men and women, especially slightly in men, but also in females, is among the top 5 cancers throughout the world, including in India and the US and other Western countries. We also try to do a routine mass screening examinations for the colorectal cancers also, for example, colonoscopies. So in a high-risk individual with obesity, with some previous colon disease, again, some family history, there are some familial cancers also which run in families in colon cancers. On a case-to-case basis, we also do some different. They are not BRCA1, BRCA2. There are different type of genetic testing to be done.
I may interrupt you a minute, Doctor. You mentioned this word strong family history. So there is, so what is a strong family history? Does it mean that, it is because we hear that sometimes it's the maternal side? What should prompt a person to, undergo all these extensive, what is a strong family history?
The consensus is building that anyone in the family actually, regardless of the type of cancer, should at least sensitize the family members to seek an opinion from an oncologist or also do a preventive health checkup. That doesn't mean that they are at a slightly, at a higher risk, because the familiar cancers are only few cancers where we have shown a strong correlation. When I mentioned strong family history, it was to emphasize the point. For example, if you have two cancers, two members in the family, especially from the same lineage, either from the father's side or from the mother's side, or common familiar cancers like breast cancer, like ovarian cancer, like body uterus cancers, colorectal cancers, some particular childhood cancers, nowadays even gallbladder cancer. There are some cancers which have anyway a familial predisposition. There we call it strong family history, where you have to have a detailed genetic counseling. By the way, I must take this opportunity to inform our viewers that Apollo hospitals throughout the country, we have embarked on a very ambitious genetic counseling program, which has already kick-started. It was already there, but now we have taken to the next level from Chairman and Dr. Sibal and many others who are involved in the program, that each unit is going to have, including our proton cancers and all the 14 cancer centers that we have, and also the general Apollo hospitals, multi-specialty hospitals, will have a dedicated genetic counselor and also a genetic scientist who will tell which blood sample to take. The genetic history counseling session goes on for hours. They have to map out the family tree and go through the intricate details about the habits, about the environment factors, about the lifestyle, and also which genetic test to be done, and such that the family is informed, they can take reparative actions, they can take, whatever decision making they have to do to safeguard their health.
I'm sorry I interrupted you. You were talking about colorectal cancers.
Yeah, I mean, that I kind of finished. So the colorectal screening has not taken off, except in some countries like Japan, Korea, where that is very, very high. So again, if you have a family history or you have some predisposing factors, there are some genetic diseases which predisposes to you develop those cancers. There, an annual or every 2 years colonoscopy is also advised. But primarily, you have to be on the lookout of significant weight loss, too much pain in the abdomen here and there. There can be other reasons also. I don't want to become overly anxious to the old people that they will rush that I have a cancer or something like that. But always, a caution is always err on the side of caution, as we say. Too much weight loss, more than 5-10 kilos in the last 3 months, or any bleeding through your stools, or occult blood in a stool examination. And some of these tests we have incorporated actually in our annual health checkup programs also, where the screening or cancer screening is also part of those health checkups that we have, that Chairman, and as you know, Dr. Shrindil, we have a very ambitious, very robust program with general population, but also with several organizations, several charity groups like Lions and Rotary, but also several corporates where all the employees. But the dream is, our Chairman dream is that every single person in this country, for that matter globally, must have a health checkup on an annual basis, which will incorporate to some extent non-communicable diseases, cancer being one of them.
In fact, I think nobody needs to even think about what screening tests, what to do when. I think it's just that a lot of it has been built in very carefully into these programs. So you just show up for it every year. I think a lot of these tests will be taken care of, the pap smear, the chest x-ray, the mammogram, and the ultrasound is all part of it.
Right. So I finished the breast cancer part of it. There are 2 or 3 other cancers where routine screening is done. One of them is cervical cancer. Now, cervical cancer is a very interesting cancer. It used to be the commonest. It is still, if you take it globally, perhaps it is still one of, and Asian countries, in LMICs, in African and many other countries still remains number one cancer. And I already mentioned in the rural population still number one. The risk factors of cervical cancer are completely opposite than breast cancer. That is early age at marriage, multiple pregnancies, multiple sexual partners. But interestingly, it is not the woman, it is actually the male who is responsible, because now we know it is caused by a virus called human papilloma virus, and there are several variants, 16 and 18. And it is on the smegma of the penis of the man, of the organ of the man, which who is actually responsible to do it to the female. So it's not the woman. We have a tendency to always blame the woman, but it's actually the man who is responsible. And therefore, the woman is at a higher risk of developing cervical cancers. Now, cervical cancers have decreased and reduced over a period of time throughout the world because of 2 or 3 interventions. Number one intervention is the pap smear. For many years ago, we realized that on an annual health checkup, wherever we are in a married woman who is sexually active, you do a small smear and you send it to the pathologist. You immediately will tell, if there are any atypical cells. They are not typical cells. Wherever they're atypical, that doesn't mean cancer, but then you have to examine them properly and take a biopsy, and it will prove or disprove. Again, beautiful, very strong scientific correlation between the curability of cancer with the stage. If you detect stage 1 cervical cancer, the cure rate is almost 95 to 100%. If you stage in stage 2, it's about 75 to 80%. Stage 3, it's about 50%. Stage 4 also you can cure about 15 to 20 to 30% of the cervical cancers. Although people tend to think stage 4 is incurable. That's not true with the modern medicine. Many stage 4 cancers can also be given a very good quality of life and also extended survival, much, much better than it used to be in the past. So cervical cancer is strong correlation with stage. So it is critical for us to detect them early so that we can treat them early. And therefore, pap smear became very, very common. Now, fascinating data came from India, including Tata Memorial and other centers, where sometimes there was a challenge of doing a pap smear in a routine screening model. Nowadays, we have the ambulances, we have healthcare vans, we have screening teams who go to village and district to district, we map them. There was an unbelievable study done in Mumbai for the last 20 years it has been done, where 150,000 women were randomized. There is no national screening policy for cervical cancer, unfortunately, in India. Still, it is only in the matter of word of mouth and sessions like we are doing now, not like a mandatory health screening like in the West. So 150,000 women in late 90s were randomly allocated to 2 groups. One group was done, and it was slums of Mumbai. One group was done where just an education was done like we are doing now. And the other group was done a screening test for cervical cancer and also clinical breast self-examination, clinical examination by a trained health worker. And the data is published. It is a major contribution to science from our country. And we showed that significant reduction of death rates, not only the detection of early cancers, but it translated into improved survival, which is actually the hardest endpoint for any screening methodology. It should reduce the survival because you have investment also, you have to balance it out. In a mass screening with a large population that we have in India, it reduced the instance and survival cure rate. It increased